Hello everyone. Excuse me. The purpose of this video is to go over discharge planning. Um, Welcome to your last week, or excuse me, we have one more week left, but the last week of assignments and yeah, let's go ahead and get started. So this is going to be pretty short and sweet. Not that it's not important and there's not a lot of information to cover. However, discharge planning looks very different from agency to agency. So I'm just covering the general purpose and general objectives of the discharge plan. But again, they may differ greatly. Also, we may work in situations where there's actually a discharge planner. Typically, this is a social worker. And discharge planning typically begins from the day people start treatment. So we're automatically from the very beginning thinking about aftercare, what they're going to need in the community, if they need a therapist or a psychiatrist, where we're going to refer them to. So something important to note is that discharge planning does not just happen at the end of treatment. It's something that we focus on throughout. Even in the inpatient unit, probably by day 2, day 3 at the very latest, we are making sure they have a safe place to discharge to. Okay, so just know that this might differ greatly. So the purpose of discharge planning is to provide support needed to sustain the progress that was achieved during the treatment episode. So we want to make sure that they set out the goals, that they met the goals that they set out to achieve in coming to treatment. To achieve continuity and coordination of care and treatment, so we want to make sure that they continue. Most agencies or modalities that we work in, the work won't end when treatment ends. It needs to continue. So we want to make sure that they have all the resources and access that they need to continue recovery. Also, to minimize the chances of relapse or immediate return to treatment. There's tons of research out there that shows that inadequate discharge planning is a major driver of remission back to treatment or relapse. And so the idea is if we can do a appropriate, extensive discharge plan, we can eliminate some of the risk of people returning to treatment, okay? Also to prevent homelessness, suicide, or being criminalized. So we want to make sure that some folks experience chronic suicidality, and that's kind of a different conversation on how to manage that. But if it's abnormal for our patients to experience suicidal thoughts, then we want to make sure that they're not suicidal when they leave. And again, there's a very big difference between intent and plan and just feeling like, oh, I wish I wouldn't wake up. Both are alarming and concerning, but having intent and a plan to attempt suicide, we would follow that very different. So in this level of care, if somebody did have the intent, means, plans to die by suicide, we would refer to a higher level of care. And if they refuse that higher level of care, we would get the Clark County crisis team involved to check on them, okay? Also, homelessness, we want to make sure that people have, at the very least, housing resources when they leave our program, okay? Another objective, to provide early intervention during crisis and relapse. So part of the partial hospitalization program modality is to intervene in crisis. And so we want to make sure that folks have the major skills to ask for help during a crisis, to cope with overwhelming symptoms, to avoid relapse into dangerous behavior, whether that be risky substance use or self-injurious behavior. So we want to make sure that they have all the tools or the resources or the referrals needed to stay safe. Also, optimal health and well-being of the patient. So One other thing that we had mentioned and talked about briefly is that having a primary care provider is of the utmost importance. Mental and physical health tend to go hand in hand. And so we want to make sure they have the access to psychiatry if necessary, therapy, as well as primary care for physical health. So we're taking a holistic approach. And so discharge planning and ensuring they have appointments set up with the primary care provider, the prescriber, psychiatrist, and the therapist is also a general objective of the discharge plan that you'll see pretty much across the board. So certain elements of the discharge plan, we're going to include typically the reason for the client's discharge. In this case, all of our patients have completed treatment, so I didn't add that as a piece on the discharge plan. We're also going to talk about mental health or substance abuse treatment and service needs at discharge, if there is any, which there will be. So again, adding information to that follow-up section about where they're going to have services after they graduate from the program or complete the program. That follow-up section covers this element here. Also, the services provided to the client while in the care of the agency. So this is where writing how the patient has met treatment objectives is of the utmost importance. Okay, we want to make sure that first of all, that they are safe, and secondly, that our programming is effective. Then the next section here, the next element, primary or significant problems or issues identified during the treatment stay. So again, we're going to list the problems and the objectives and how they were met. Typically, we would do a mental status exam at discharge also. Obviously, there's barriers to why we haven't done that here, but just know that typically we would assess functioning by doing a one-on-one session, or in the mental health specific mental status exam, to kind of compare how they've progressed or degressed over time. We're also going to provide referrals for ongoing mental health and substance abuse treatment if needed. We're also going to provide referrals for recovery support, so community and social recovery support. So again, we're going to explore that in the recommendation section. We want to know what agency, therapist, or psychiatrist that the individual is being discharged to, and then any other information related to patients' achievement of treatment goals or outcomes. So assessing for specific needs. So we want to see, and again, if we were doing the mental status exam, all of these things would be covered, but just so you know, moving forward, we want to know that they are able to care for themselves. Okay, so self-care can mean a couple different things. It can be regarding ADLs, which are activities of daily living. Are they able to cook? Are they able to clean? Are they able to shower and take care of their hygiene? Are they able to get to appointments? So we want to make sure that they have the capacity to do this. And we also want to emphasize how they're going to be kind to themselves and how they're going to take care of themselves after treatment. So I know here in the ADAPT program, we have a Life After ADAPT group. And so we talk about structuring our lives, the importance of fun and social connections and having a purpose. And so having a conversation about those things. How am I going to keep myself safe? How am I going to care for myself in a way that perpetuates positive mental health? We're also going to assess for clinical needs, so identify the potential predisposing factors that can lead to distress or relapse. So along with the crisis plan, typically during the program, folks would be doing a relapse prevention plan. If you are familiar with SUDS work, you've certainly seen this before, but we also do relapse prevention plans for certain extreme emotional states like mania. So for instance, when I'm in a period of mania, this is how I'm going to keep myself safe. Okay, so we can do relapse prevention plans for specific mental health symptoms also. We also want to make sure that we're informing the patient of the importance of sleep hygiene, nutrition, lifestyle modification, how to deal with barriers or anticipated adverse effect of medications or social, interpersonal problems. How is the patient going to best work through those issues? Let me see here. Again, we're not going to be doing this here, but especially in the inpatient sense, we really want to make sure that the family is involved in the treatment plan, assuming that the patient allows it. Because what we know about mental health and SUDS for that matter is that it's never just about the person who's getting treatment or causing the issues, if you will. Addiction and mental health is a family disease. And so with that being said, we want to have families involved as much as possible, especially regarding psychoeducation of how to best support the patient. Okay. Other needs, so assessed domains such as socioeconomic, cultural, and spiritual needs. Discuss where the patient will stay after discharge. This is very, very important. They need a safe place to go. Oh, sorry about that. Okay. Oh. Okay, moving forward. So arranging other services. So community services available near the person's area can be utilized for crisis management, supervision, support, compliance check, etc. We should evaluate such services and examine which ones will best match the particular needs of a specific patient. So we are going to see what their community and social needs are, and we will explore this throughout the treatment episode, but also most people don't know what community agencies or services are out there. And so part of our job is to educate them on those resources that are available. If necessary, community-based services such as halfway homes and group homes should be recommended to the patient if they are available, as they can provide sufficient care and support during the period of transition to community living. So a couple of places that we might refer people are Elahan Place, if that's something that you want to look into. We also may refer folks to Oxford Housing where they can get supportive recovery support. So that might be something that you add to your discharge plan also. Okay. Involving the family. So again, we're not going to involve the family in our discharge plan. However, moving forward, just know that I'm not going to give you the spiel again, but there's reasons why we need to involve the family, and it's essential to keep them in the loop, assuming they've provided a release of information for them, especially in closed ward settings where the patient is admitted without any bystanders. The patient's progress during the hospital stay and how ready they are for discharge should be periodically discussed with the family. One study pointed out that satisfaction in discharge planning drops when there is no contact between the staff and family regarding discharge. Okay. So again, just going back to discharge planning should begin immediately after admission and be updated throughout the inpatient stay. We should ensure that the discharge plan sufficiently addresses the practical and social reasons that influence the admission. For example, if a patient with schizophrenia has been readmitted due to relapse following medication noncompliance since he is living alone, or if a female patient with severe depression has a husband who suffers from alcoholism, such issues should be addressed during the discharge planning. Okay, so that might be part of the recommendations that we make for them. Also, something that we are not doing in this assignment, but something that we may be asked to do out in the field is getting folks hooked up with the, I'm sorry, I'm losing my train of thought here. ombudsman. So Clark County has an ombudsman. Recently, she had passed away, but they did. We do have a new mental health ombudsman, and that person actually comes into the program that I work at once a month to explain the rights of folks with mental illness. And so we should attempt to educate the patient about the changes in the Mental Health Act. The discussions should include the planning of advanced care directives. And again, an advanced care directive is just something that states that somebody is in charge of my medical decisions when I'm experiencing severe symptoms. There's also one for physical health as well. So we need to explain to them what those are, what they're for. They should also be informed about the rights of a person who has a mental illness, specifically the right to confidentiality, the right to access medical records, and the right to legal aid. Clarification about the release of medical records and its restrictions should also be considered. So again, I think we've talked about this before in a Zoom meeting. The way the behavioral health medical records work is sometimes, depending on the situation, they can be harmful or cause harm. And sometimes this is implicit, and sometimes this is just a misperception of the patient and the clinician. We tend to see a lot of discrepancies for folks with personality disorders. So when they see their medical record and they're like, I actually don't have borderline personality disorder, I disagree with the doctor. So there can be some issues in folks seeing their behavioral health medical records. And Peace Health actually has a team that determines whether it's appropriate or not. We also get to have a say in whether somebody sees their documentation. There's maybe 1 out of 50 where I've said no. And again, the reason for that is because I think it would cause a lot of harm to this patient. Otherwise, I believe that folks should have access to their medical records at any time. And so I'm a yes guy in that sense, constantly saying yes to records. Let's see. Again, if you don't know what an ombudsman is, please look into it. We should especially be familiar with who the Clark County Ombudsman is and their contact information. If I remember, I can try to add it to this week's module. Moving on to crisis planning. So again, there is a really comprehensive assignment description under assignment 6. And so all the steps will be in there, but just quickly, the purpose of the crisis plan is to identify warning signs that a crisis might be developing, to identify coping strategies that patient can use when experiencing crisis, to identify people in social settings that provide distractions, to identify things to add or remove in the environment to make it safer, and to identify support people, professionals, and agencies that the patient can reach out to in times of crisis. So when it comes to warning signs, you might say something like, the patient might say that they isolate more, that they use more substances, or they think about suicide a lot. So those would be some warning signs. Coping strategies, so things that have worked in the past or things that they have tried in the program that can help when experiencing intense emotions or symptoms. And then we're going to identify where and with whom folks feel the most at peace, that can provide distractions for them. And then adding or removing things in the environment. So for example, we might want to remove razors or drug and alcohol paraphernalia, or a troubling partner for that matter. And then adding comfort items to be helpful in a crisis, such as a weighted blanket or aromatherapy, something like that. Also identify support people, professionals, and agencies that patient can reach out to in times of crisis. One of the major ones that I will require everybody to have on their crisis plan is the Clark County crisis line or your county crisis line. The crisis line also has a text line that might be beneficial for folks. And so always having a plan on who I can reach out to when I'm experiencing crisis. Again, if you have any questions at all about this, please email me and we can set up a time to Zoom or talk on the phone if necessary. I will try to get back to your emails within 24 hours. I do realize this is the last assignment and there's a lot of things that are coming due here. So please do not hesitate to reach out to me.